Herpes zoster, or shingles, is caused by the reactivation of the varicella-zoster virus, the same virus responsible for chickenpox. After primary infection, typically in childhood, the virus establishes latency in the dorsal root or cranial nerve ganglia and may reactivate years later, especially with advancing age, where risk increases significantly after 50 years. Immunosuppression from HIV, chemotherapy, organ transplant, or stress. The lifetime risk is approximately 1 in 3 people in the U.S., with about 1 million cases annually, and incidence rising to 10 per 1,000 person-years over 60. This virus remains latent in nerve ganglia and can reactivate years later, especially with age or immunosuppression. The diagram shows a simplified human nervous system with highlighted dorsal root ganglion, where VZV becomes latent post-chickenpox, then reactivates, traveling down sensory nerves to skin, causing dermatomal rash. Triggers include age-related immunity decline from 1 per 10,000 yearly in 20s to 1 per 100 in 80s, immunocompromise like cancer treatments or HIV, explaining unilateral, non-midline crossing rash. The hallmark is a painful, unilateral, dermatomal vesicular rash, often preceded by neuropathic pain. This close-up photograph of a pale man's upper back and right shoulder shows large, irregular purplish-red raised bumps in blotchy, map-like dermatomal pattern indicating shingles. Prodromal days 1 to 7. Burning, stabbing, electric shock pain, allodynia, fever, malaise, headache, misdiagnosed as MI or musculoskeletal. Rash days 2-7, maculopapular to vesicles, unilateral thoracic, 50 to 60% common. Vesicular days 3 to 10, contagious new crops. Crust days 7-14, healing start. 2 to 4 weeks, resolution, pigmentation changes, scarring rare. PHN pain 90 days 10 to 18%, risk higher, 80 50 to 70%. Risks age 50, severe pain, extensive rash. Diagnosis is typically clinical, based on characteristic dermatomal pain and unilateral vesicular rash not crossing midline, classic triad. Atypical or immunocomp use PCR, VZV, DNA, vesicle fluid, gold standard 95 to 100%, DFA 90%, ZANC 60 to 70%, multinucleated giants, serology not acute. Special, HZOV1, trigeminal Hutchinson sign keratitis, 65% uveitis, vision loss. 50% untreated urgent ophtho, disseminated immunocomp 20 to 30%, Ramsey-Hunt 7 facial palsy, zoster sine herpet pain, no rash, PCR. Antiviral therapy such as acyclovir 800 mg PO 5 times daily 7 to 10 days, valacyclovir 1 GPO TID 7 days, better bioavailability, famciclovir 500 mg PO TID 7 days, most effective within 72 hours, rash onset reduces duration pain, PHN risk about 60%. Flowchart shows antivirals, pain, paracetamol, NSAIDs, mild opioids, severe, adjunct gabapentin, 300-900 mg TID, pregabalin, TCAs, amitriptyline 10-25 mg, HS, lidocaine, 5%, capsaicin, 8%. Ophthalmic urgent ophtho, systemic plus topical, immunocomp IV, acyclovir, 10 mg corgiejar, Q8H7 10D, dissemination, visceral mortality 5 to 15%. Vaccination with Shingrix, recombinant zoster vaccine. RZV, most effective prevention, recommended adults 50 plus, immunocomp 19 plus, non-live GPE, AS Duro 1B adjuvant. 2 IM doses 2 to 6 months apart. 97%, HZ efficacy 91%, PHN 50 YO, 68 to 91%, immunocomp durable, over 90% to 70 plus, outperformed Zostavax, discontinued 2020. Hygiene, avoid contact until crusted. HZ potentially debilitating, older immunocomp, early recognition, antivirals. 72 age pain control vaccination, key reduce PHN, vision loss complications.